I did my case study over a patient who had overall spinal dysfunction. The two different types of spinal dysfunction that my patient presented with were severe spinal stenosis as well as cervical myelopathy. The first one being spinal stenosis. A brief definition of it is basically the narrowing of the spinal canal leading to symptoms such as pain that leads down the legs that often presents with prolonged standing. The cause of spinal stenosis is often due to osteoarthritis, changes within the spine, and some risk factors that can lead to this type of stenosis is age, being over 50 years old, and it's more common in females over males, arthritis, and a history of low back pain. Some things to avoid are high impact activities, and then just some common symptoms within patients include pain, numbness, tingling, and weakness that is present in bilateral legs or feet. The second type of disorder is cervical myelopathy, and this is spinal cord compression within the neck, and it is most commonly due to degenerative changes within the spine. Some common risk factors include a sedentary lifestyle, age, obesity, cervical alignment, and then high participation in contact sports. Some specifics within evaluation include specific gait mechanics, positive reflexes, Lermite sign, Hoffman sign, and several others. Some common symptoms that patients experience are stiffness and pain within the neck region, loss of balance, trouble walking, and radicular symptoms. And then common treatments include either conservative or surgical route, the conservative being NSAIDs, physical therapy, modalities, and injections. And then the cervical route is either performing an anterior or posterior approach to increase the canal space to help with that compression of the spinal cord. It really depends on the clinician and what exactly they want when it comes to considering surgery. If there is a progression of symptoms, more than 6 months of issues or of increased symptoms, and then at that point the timeliness of the surgery is critical. In patients with milder symptoms and with them experiencing symptoms of less than 6 months, often have an improved outcome after surgery. So more into specifics of my certain patient. She is an 82-year-old female. She is a retired teacher and volunteered at a grandkids' school. Some aggravating factors for her were walking for greater than 20 minutes, standing for greater than 10 minutes, and then specifically driving and pressing down the gas pedal really increased her symptoms within her back and her right lower extremity. Some of the relieving factors are really just up and moving around, not being stagnant. And then just some hobbies that she enjoyed were card games, reading, and teaching. Her surgical history, she did have carpal tunnel release and trigger finger release performed in 2021. And then her overall goals within her first evaluation, she mentioned that she wanted to lose a few pounds, get into physical therapy, walk 2 miles at a good pace, and then stand and drive with overall less back pain. And then she lives with her husband in a 2-story home with the main bedroom and bathroom on the first floor, as well as the laundry in the kitchen. And then she did have 6 steps to enter the house through the garage, and then there was no additional pertinent information within the family history. The patient has been coming to physical therapy on and off ever since 2019. During her initial evaluation then, she first started coming to PTE because of her severe spinal lumbar stenosis. And at this time, she was receiving lumbar injections every month for pain relief. And then fast forward to 2020, she had low back pain still, as well as right-sided radiculopathy, and she demonstrated restrictive lumbar spine movements, specifically in extension and rotation. In 2021, this is when she first started noticing a weakness of her right hand and wrist, unsure of what it was attributed to, and then also noticed swelling in her first digit. She was diagnosed with degenerative disc disease as well as arthritis and presented with a decreased sensation along the median nerve distribution of her hand. And this is when she started not only doing lumbar injections but also cervical spine injections for relief, but the cervical spine was more so relief of the numbness and tingling sensations. And then in 2022, she had a continuation of both her right upper and lower symptoms. She had limited right shoulder mobility and also had a continuation of tingling and numbness present in her right-sided arm and hand. At this time, the doctor thought her tingling sensations were attributed to carpal tunnel and had surgery performed to release that, as well as trigger finger release performed, although the doctor did not think this would solve all of her symptoms, and thinking it was more still coming from her cervical spine instead. And then in 2023, the patient started demonstrating upper motor neuron signs such as a positive Babinski's and Hoffman's, drop foot. She was hyperreflexive of both her patellar and Achilles, and then demonstrated some tone as well in that right upper extremity. At this time, she was diagnosed with cervical myelopathy, although declined surgical interventions for both her lumbar stenosis and cervical myelopathy, despite the severity of symptoms at this time. And then she also demonstrated a positive upper limb tension test with all 3 nerves, including median, radial, and ulnar. And then towards the end of the year, she received a rigid AFO for her right foot because she did demonstrate drop foot. And then fast forward to 2024, because she declined surgical interventions for both, there is a continuation of right-sided symptoms as well as progression of muscular atrophy. Here is a list of medications that my patient takes. Basically, the overall use of the medications are for high cholesterol, hypertension, nerve symptoms, and overall pain relief. Because my patient has been seen in physical therapy on and off since 2019, more of an update on her condition is that she was diagnosed with cervical myelopathy in 2023, although she declined surgical intervention for decompression due to the risks associated with it, as well as a lack of guarantee. At this time, my patient no longer has use of her right hand or wrist, and she is unable to actively make a fist with her fingers. And she does wear a brace on her right side just for additional support and protection. And for management of her right-sided drop foot, she does wear a rigid AFO to assist with ambulation. And then just some specifics of her gait mechanics. She demonstrates a slow cadence, a right hip hike, mild right toe drag, decreased step length, decreased step height, and decreased stride length, as well as a narrow base of support. Here is a chart displaying overall pain, weakness, and numbness that my patient was experiencing. One of the biggest things is that she never experienced pain within her right upper extremity, just that numbness and weakness. And then on her right lower extremity, this is where she demonstrated that low back pain, as well as pain, the sciatic pain that ran down her right side too. Prior to 2019, my patient was overall relatively healthy and active, and she walked up to 2 to 3 miles per day. She retired from teaching in 2021 due to her debilitating back pain, as well as her radicular symptoms down her right side. At this time, my patient is unable to drive due to her right drop foot and overall weakness of both her right upper and lower extremity. And then she is able to ambulate without an assistive device, although she does wear a rigid AFO. And she also presents with poor balance and proprioception. And then she does demonstrate severe weakness within both the right upper and lower extremity, as well as mild numbness is present, and then specifically more so on the right side on the bottom of her foot. Some clinical tests that my patient experienced: she received an x-ray in 2021 and it stated that she had degenerative disc disease. And then in 2019, she received an MRI diagnosing her with L4, L5 severe spinal stenosis within her lumbar spine. And then in 2023, she was diagnosed with cervical myelopathy. And then in 2021, she received an EMG, and it stated that she had median nerve motor loss, and this was ultimately led to her carpal tunnel syndrome. Since my patient presented with a variety of different symptoms, some diagnoses that were ruled out were brachial plexus involvement, central cord syndrome, as well as Chiari malformation, and then the two that were ruled in were severe spinal lumbar stenosis and cervical myelopathy. An overall systems review for my patient is that she presented with an appropriate skin integrity with no signs of open wounds or edema. Her vital signs remained within normal limits, although she did have high blood pressure, but she was medicated for it. And then the patient presents with normal communication, cognition, language, and memory. Here is a table highlighting the outcome measures that were used throughout my patient's physical therapy experience, such as the DASH oswestry, the lower extremity functional scale, ABC, functional gait index, mini best tests, as well as 5 times sit to stand. One thing to note is that in 2023, the doctor wanted to shift focus more specifically to low back pain because it was no longer beneficial to treat the right upper extremity as her symptoms continued to progress without specific surgical intervention. This is just a further examination and a description of the normative values of all of the outcome measures that we used for this patient. This is a chart highlighting the manual muscle tests of specifically the lower extremities. As you can tell, it was pretty normal within the first couple years that the patient went to physical therapy, and then really in early 2024 and late 2023, you can see where she started to experience some pretty drastic changes within her right side. This chart is specific for manual muscle testing of the upper extremities, and once again, early on in the patient's physical therapy experience, she demonstrated relatively strong manual muscle testing, and then demonstrates a more drastic loss of strength beginning in early 2023. So the overall proposed mechanism of onset with my patient, first off, lumbar spinal stenosis. She was greater than 50 years old. She was a female, as it is more common in females. She did have an arthritis and increased swelling present, as well as a history of low back pain. And then my patient's specific presentation within lumbar stenosis was low back pain, radiculopathy, numbness and tingling in the lower extremity, loss of sensation in the feet, and then as well as foot drop on that right side. And then with cervical myelopathy, she is greater than 55 years, and she is female. Her age presents greater than the 55. She has a relatively sedentary lifestyle, and then cervical alignment, poor posture, and lack of range of motion. And then her specific presentation was increased weakness of the right upper extremity. She was unable to actively make a fist. She demonstrated upper motor neuron signs. She had weakness of proximal lower extremities, difficulty with fine motor skills, loss of balance, as well as trouble walking. And then overall, both of these two types of disorders are caused by degenerative changes within the spinal cord. Here is just an in-depth list of the certain diagnostic classifications that were used within the International Classification of Diseases. The patient's specific prognosis is determined to be poor due to the decline of surgical intervention with a progressive condition leading to paralysis of nerves. Here are 4 short-term goals that were determined for my patient, overall being flexibility, adaptations to move around in her bed, demonstrating compliance with her home exercise program, and then being able to brush her teeth with her non-dominant hand. Here are several long-term goals for my patient, several of them being standing for prolonged amounts of time, increase in overall flexibility, negotiating stairs, and increasing ambulation distance, all without any increase in pain. Some specific intervention techniques that were used were just overall dynamic movements to improve the patient's functional performance, and these are more geared towards promoting patient independence, as well as gait training with an emphasis on that foot clearance and improving balance and posture throughout the different tasks to decrease the patient's risk of falling. We utilize manual therapy techniques, specifically within the cervical and lumbar spine, to assist with pain modulation, as well as soft tissue massage of certain muscles to assist with enhanced flexibility. And then we also would use therapeutic exercises of the upper and lower extremities, as well as the core, to address present limitations that she is experiencing, and then as well as active stretching to address the flexibility limitations of her gastroc, hamstrings, piriformis, and hip flexors. Here is just a continuation of the interventions that were used for my patient, such as neuro reeducation, modalities, and home exercise program. The first one being neuro re-ed, and this is where we utilize certain balance exercises, P&F patterns, and then overall just to help assist with developing strength, muscular control and coordination, and stability, as well as mobility. And then some modalities that were used were hot and cold packs, as well as e-stim, and these were just used to assist with the pain modulation. And then lastly, developing a home exercise program for the patient, just to assist with progress and maintenance outside of the clinic in terms of strengthening and stretching and improving overall postural and enhanced stability. Overall, the patient made improvements early on with physical therapy starting in 2019 in terms of strength, flexibility, range of motion, as well as pain relief. Once she started experiencing a new onset of symptoms over time, it was harder to maintain that progress. She continued use of epidural injections, both in her cervical and lumbar spine, which she received mild pain relief with. And then over time, her function ultimately declined after developing drop foot and paralysis of her right upper extremity. Due to the patient declining surgical interventions, these symptoms experienced were not going to get any better, and she ultimately declined surgery due to the risks associated with it, and ultimately not knowing if surgery would cure the symptoms that she was experiencing. And at this time, she relies on compensatory techniques during ambulation due to weakness and poor motor control of the right lower extremity. And the patient continues to attend physical therapy to assist with maintaining independence, to focus on functional activities, to preserve as much muscle activation as possible. I did my research specifically looking at the difference between taking the conservative versus the surgical route. The first one is in specific to cervical myelopathy. The conservative treatment includes immobilization, medication, lifestyle modifications, as well as modalities. Although this can be beneficial for some, it is not recommended if the patient has experienced a progression of symptoms or experienced symptoms for greater than 6 months, as well as if the overall transverse area of the spine is not within the normal limits. The surgical approach is superior in terms of regaining function as well as pain relief. The study showed improvements over time with surgery, whereas a decline when taking the conservative route. Although surgery is the superior route, with this study that I looked at, the timing of surgery is crucial for an optimal outcome. Those that demonstrate clonus and a greater compression of the spinal cord have a less favorable outcome. And then although there was a risk for post-operative complications, they ultimately did not affect the neurological outcome of both groups that were tested, and then both groups did exhibit a significant improvements, whether they did the conservative or the surgical route here. Oftentimes, the epidemiology is often misunderstood with cervical myelopathy due to the difficulties in diagnosis. Oftentimes, there are other features with other neurological disorders that can delay the progression, since they do have features that overlap. And then a study stated 43% of these patients had symptoms of numbness and pain in hands and were initially diagnosed and sometimes treated for carpal tunnel syndrome, which in my patient scenario, this is what happened. Secondly, for spinal stenosis, the conservative approach is more common for those with this type of diagnosis, including injections, medications, rest, physical therapy, and modalities. The conservative approach is best for those with mild to moderate degree of symptoms and is recommended up until the symptoms become unmodifiable. Surgery is then indicated if the patient has loss of ability in their daily life, and it is recommended if the patient is experiencing overall progression of symptoms. The long-term outcome of these approaches demonstrates similar results, and it ultimately depends on the severity of the neural compression. Depending on the severity of these two spinal dysfunctions, it can lead to significant and permanent nerve damage causing paralysis, and these risks associated with either of these can lead to constant pain, discomfort, decreased level of activity, as well as loss of bladder and bowel control. In conclusion, the patient opted out of surgical intervention of both cervical myelopathy and severe spinal stenosis, even though she was experiencing a progression of symptoms with both diagnoses. Surgery was declined due to the risks associated with it, the unknown of surgery, if it would help or not, as well as the lack of education she received from her healthcare providers. The patient never experienced any neck pain, therefore she did not see the reasons for cervical decompression surgery, even though she displayed symptoms elsewhere. Her symptoms continued to progress, and once she lost function, it was too late to perform surgery. Early on in the patient's experience, she demonstrated improvements of overall symptoms related to low back pain and radiculopathy in terms of flexibility, strength, and pain reduction, but that is no longer the focus at this point, as she is experiencing progression of weakness and paralysis of nerves. Physical therapy is now maintaining the patient's independence as much as possible while emphasizing the muscular activation that is currently still present. And although compression of the spinal cord will continue, physical therapy will continue to assist with maintaining as much function as possible.